Hello and good evening, everyone. Welcome to our 81st Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Hills Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Iheno Taddala, a general physician and first aid trainer from Blue Hills Ethiopia. Today, it's a pleasure to have Dr. Surafel Desalegn here with us to have a presentation on the basics of mechanical ventilator. Dr. Surafel is an assistant professor of emergency and critical care medicine at the University of Gondar. He received his degree of Doctor of Medicine from the University of Gondar and did his specialty at St. Paul Hospital. He has over 5 years of experience as a physician, giving clinical services and involved in multiple research activities. Dr. Surafel is an American healthcare, Dr. Surafel is an American Heart Association certified advanced cardiac life support instructor and provider. So, Dr. Surafel, the stage is all yours. You can begin.
Okay, thank you, Dr. Iheno, for the warm welcome. So I'm here, as you have already mentioned, I'm Surafel. I'm an emergency and critical care physician, and I'm currently working at the University of Gondar. So what we basically try to see today is just for the basics of mechanical ventilator. So I would like to warm up some ideas on the basic topics and what are the major troubleshooting procedures, especially those working in ICU. They usually face very much difficult and critical ill patients to manage. So how do they at least troubleshoot? How do they initially set the mechanical ventilator? All the things related to that will be discussed. So as a disclaimer, it's not an advanced topic as you have already imagined. So it's not that much advanced. It doesn't go for alarm setting. It doesn't go for troubleshooting. So it's a very wide topic. But at least we will try to cover the basic topics of a mechanical ventilator and initially putting it in mechanical ventilator with the allotted time. So I will try to make it easy for you guys. And so for if there is any ambiguous questions, you can raise on the chat box as well as on your.
Okay, so we will try to see the outlines. So at the beginning, we will try to see based on the historical aspects, what historical parameters do we have since the beginning of the negative pressure, positive pressure ventilation. How do the modern ventilators are working now, and when was it created? So just general overview, physiology of breathing, how is the breath delivered for a patient on admission, and what are the common indications for use of mechanical ventilator? Most of you who work in the ICUs know about these things already. So what are the types of positive pressure ventilation? What are the modes and the physiologic consequences, the troubleshooting? So we will try to address these topics as we see the general overview. So the objectives for you guys are, at the end of the session, you should be able to list up some of the indications for mechanical ventilator support, what are basic terminologies regarding mechanical ventilation, what are the difference between non-invasive positive pressure and invasive positive pressure ventilation. So how could you differentiate in between the different modes, physiological consequences, and finally we will try to see the troubleshooting. Okay? So as you all know, taking a patient to a ventilator is not an easy process. Okay, sorry for the inconvenience. So what was the primary goal for mechanical ventilation? I was asking a question.
Okay,
so anyone can find.
Participants can write down the answer in the chat box.
Okay. So the main primary goal of mechanical ventilation, as we have already talked, so the primary goal is just to have a support, and the secondary goal is avoid complications related to the mechanical ventilation. So ideally, it's better to avoid any complications related to the mechanical ventilation, but the primary goal is to meet the clinical objectives that you use the mechanical ventilation for. So the historical aspects regarding mechanical ventilator dates back to 5th century BC. As you can see, This is Hippocrates. He was the one who introduced the idea of introducing a tube into the trachea so that the lung can be ventilated with a positive pressure. So the idea, this was just the idea that brought in around 500 BC. So you can see how the history of mechanical ventilator dates back. And then next there was the idea of Paracelsus. I think every one of you know about this thing. I think they usually use it in a, what do you call it? So they usually use this for a fire bellow. So for a fire bellows, okay? So this was used for a patient, especially awake patient who can breathe by his own. They usually use to ventilate with pulse pressure ventilation, as we can see on the picture. And next to that, there was also some scientists like Andres, but already create an opening towards the dog trachea, and there was a mouth-to-mouth breathing was introduced in around 18th century. And you can see all the growth that you see in the 19th century. And it was a body tank ventilator. So this was a breakthrough ventilator that was developed when there was a polio epidemic around the 19th century. There was a polio epidemic. So it was created for means of a negative pressure, positive pressure, and a negative pressure ventilation, so that a vacuum will be created in this ventilator, so that the air will be drawn into the lungs. Can anybody hear me now? I think it's audible.
Yes, it's audible, and participants are writing down their answers.
Okay, good. So this is a slight modific of the body tank ventilator. So this is called the iron lung. The iron lung. So what was the drawback? The drawback usually is very much difficult to give nursing care for patients. As you can see, there is only one opening. Otherwise, it's a very closed space. So you can't have a nursing care for such patients. So the patients usually have some other complications other than this process per se. So this was a very significant difficulty that patients were facing. So, and it was initially used in a rich American financier, if you remember maybe the history. So he was visiting China and he was attacked by polio, and he was put on an iron lung. And he fathered 3 children actually. He was married and he stayed in this iron lung for more than 2 decades. So you guys can't ask me how he really did that because it's very difficult. I don't know how you can father a child while you are ventilating this complete iron lung, but he actually did. So in my opinion, as a point of view, either you need to suppress your libido or die trying in this patient. So anybody know about this? The one in the iron lung, anyone know about this one? Can anyone write it on the chat box? Do you know this guy? Yes, he died recently. Someone is responding. He died recently. Yeah, he actually died recently. At least I think it's 1 or 2 years back. So it's called Paul Alexander. He was attacked with the polio epidemic at the age of 6, and he lived in this iron lung for the past like 74 years. But he was able to train his breathing in the absence of the motion by himself. So he's a great artist. He's a great artist. He's a great poet. So I think we can give you an overall overview of the previous history of the mechanical ventilator history. So, and there is also cuirass. Cuirass is just, it looks like a defensive armor for those who are sword warriors. So this is where the positive pressure ventilation, the idea of positive pressure ventilation started. Okay, this is a positive pressure ventilation. Drager's pulmometer is also positive pressure ventilation. So it's not yet until the mid-1950s, 1940s, the scientists were using the idea of negative pressure ventilation to ventilate patients. So the idea of positive pressure ventilation started around mid-90s, 1950s, 1940s. So this is what you see. The modern mechanical ventilator, I don't know what type of mechanical ventilator you're using in your clinical setup. What are the most common? I think you're using Philips Mindray. Can you write it on the chat box so that I can tailor the body parts depending on your machine, depending on your commonly used machines? in your ICU setting or emergency. I think Mindray, someone is answering Mindray. I think it's the commonest one in all of the ICUs in most of the Ethiopian parts. Okay, Philips. Okay, good. So most of the modes, most of the troubleshooting we discuss from here now, we'll focus on the Mindray and the Philips. Actually, it doesn't change the basic idea of the mechanical ventilator doesn't change. Okay, if you understand the basics, then you won't have any problem dealing with any of the motions. So you just need to revise the manual that you are using. So as you can see, there are different structures. This is the external surface anatomy of a mechanical ventilator. This long metal supporting arm. This one is a support arm. In number two, as you can see, is inspiratory port with a filter inside it, and this is the expiratory port story, and with the active humidifier here. Number three is an active humidifier. This is a trolley, and this large part here is a compressor. So a compressor for most ventilators, you can use a compressor, but it's currently being an optional one because they usually have a built-in compressor to drive the air in. And these are the water traps, so they should be placed in a gravity-dependent area so that the water traps will not fill the circuit. So it should be gravity-dependent. It should be put well below the patient's level, okay, the patient's level. And this circuit that enters into the active humidified and enters into the motion. Enters into the motion. This one is, it does enters into the patient is the inspiratory. So this is the inspiratory gas flows into the active humidifier. The air will be humidified here, and it will follow the course and enters into the patient. And as the patient actively expires, it will follow the expiratory and into the motion. So this is the inspiratory and expiratory circuiting. This is the test lung or artificial lung, and this is the ET tube, as you can see in the top. The eighth one is a flexible connector, so it will flex. So this is not a must, but you can use when it's available. So is the basic anatomy clear? Is everyone clear? Okay. So I will proceed. So as you can see, the types of respiratory failure that are major indications in general for institution of mechanical ventilation are type 1 and type 2. So previously it has been classified as 4 types, meaning type 3, type 4, post-operative atelectasis. All this, as you can see, they can be bundled up into these 2 major classifications, either predominantly hypoxemic respiratory failure or predominantly hypercarbic respiratory failure. In most of the cases, hypercarbic respiratory failure has some sort of oxygenation problem as well, but usually you can classify based on these 2 topics, okay? So this is just a clinical diagnosis, type 1, type 2 respiratory failure, but there are also arterial blood gas diagnosis, okay? You can do arterial blood gas analysis. So if arterial saturation oxygen below 90% with FiO2 means fraction of inspired oxygen 60% and above means you are using inspired oxygen fraction above face mask, above the delivering capacity of the face mask oxygen. If the arterial saturation is still below 90%, you can say it's hypoxemic respiratory failure. So the usual causes are usually alveolar or predominantly lung problems, as you can see. Lung infections, pneumonia, ARDS, identified with syndrome, and pulmonary edema. So these are the commonest causes. In the hypercarbic respiratory failure, patients usually don't have significant amount of oxygenation problem, but they usually have respiratory muscle fatigue or obstruction. So they usually tend to retain carbon dioxide. So the PaCO2 level based on the ABG analysis will usually be above 50 millimeters of mercury. But beware, this does not work for those patients who are habitual oxygen retainers, especially COPD patients. To say there is a really rising PaCO2 level, we need to have a baseline and we need to follow the PaCO2 level really, whether it's increasing or not. And you can also use the pH. So mainly ventilation abnormalities are related with hypercarbic respiratory failure. So neuromuscular disorders like patients with Guillain-Barré syndrome, for example, come into it for hypercarbic respiratory failure. Asthma patients and drugs like opiates or benzodiazepines that can depress respiratory drive can lead to respiratory failure. So the types of ventilation, they can be delivered either invasively or non-invasively. So the part that we focus today will be on the invasive one, okay? So the non-invasives are usually don't use interfaces that pass the vocal cord. So any interface, any tube that passes the vocal cord is considered as an invasive one. So be it a tracheostomy, trichothyrotomy, or an ET tube that passes the vocal cord. So it's considered as invasive posterior ventilation. All the things that can be, all the posterior ventilation that can be given through interface other than the AT tube or other than a tube that passes the vocal cord, like face mask, a tent, another mask, can be considered as an invasive posterior ventilation. So our focus will be on the invasive one. So you can write down your questions. If there is any question, I can answer. It's clear. I'll continue. Okay, so the difference intubation is mainly for securing the airway. So for those patients with depressed mentation, airway reflexes, anything that creates a problem in the control of the airway might need intubation or a pass. Okay, then comes ventilation. So ventilation is not only for tube passage or creating a conduit, it's just for resting the muscles until the underlying process is improved. So it could be indicated for patients with hypoxemia, hypoxemic respiratory failure, hypoventilation. So those with unacceptable high work of breathing, those with cardiorespiratory arrest, refractory shock, even raised ICP might be an indication for therapeutic hyperventilation and all the other indications. So it depends on the condition. So you can create a picture in your mind that there is a master controller here, which is the central nervous system and the musculoskeletal systems, including the thoracic cage and the lungs. So, and there is a wiring, which of course is a peripheral nervous system here that can control the thoracic cage and the lungs. And there is airways, the upper airways that leads to the lungs. So any problems in these parameters can result in the need for ventilation. So airway can mention obstruction, epiglottitis, laryngitis, vocal cord paralysis. On the thoracic cage, you can consider leg tests from traumatic causes and any vestibular deformity, extra circumferential burns. In peripheral nervous system, you can consider Guillain-Barré syndrome, which is a commonest condition in our setting, and then system, including drugs, stroke, and the lungs, of course, are the major pathologies that we face in our daily, our routine ICU activities, especially ARDS, COPD, heart failure, and the likes. So I think it's clear still now. So what are the objective criteria in general for intubation ventilation? This is a very wide topic, so I'll generally try to summarize it based on the measures of oxygenation, measures of ventilation, and measures of vital performance. And you can ask me if what each parameter mean to you. So you can ask me at the end of the seminar. Otherwise, it's a very wide topic. So PO2 can be assessed and can be used as an indication, as an objective indication for ventilation. Alveolar arterial gradient, which is the most commonly used, but we need to have the ABG. So most of these oxygenation parameters that that I have mentioned here are usually for ICU settings with ABG analysis, ABG analyzers. So I don't know how much of you are really using ABG analyzers. So I think there are private ICU settings in Addis that are currently using ABG analyzers. So you can use these things to assess your oxygenation parameters. And the commonly used ones are PO2 5 ratio, which is actually the definition for ARDS, which is the Berlin definition for ARDS is the PO2 5 ratio. There are measures of ventilation which really use pH, the DDVT or daily space tidal volume ventilation or ratio, and the PaCO2 level are usual measures of ventilation. And there are also measures of respiratory muscle performance, especially useful for neuromuscular disorders. And you can also assess them to assess the readiness of the patient for weaning. It's respiratory muscles working fine. The patient has critical illness-induced myopathy. All these things can be assessed by using the measures of respiratory muscle performance. So is my voice clear? So if there is any problem, you can ask me in the chat box.
Yes, it's clear, Doc.
Okay. So the normal mechanics of spontaneous ventilation, you can remember the Boyle's law. So whenever a body or a thoracic cavity tries to increase the volume by creating a vacuum, the diaphragm sits down and it will create a more negative pressure inside the thoracic cavity, as you can see. So the more negative pressure there will be, the partial pressure of oxygen in the thoracic cavity will become low as compared to the atmospheric pressure, so that air will preferentially enter into the trachea and into the lungs. So this normal respiratory motion depends on the Boyle's law. But this varies when you apply a positive pressure by the use of mechanical ventilator here to drive oxygen into the, or drive a gas flow into the chest. So there should be a pressure difference between the intrathoracic cavity and the outside atmospheric pressure in the case of spontaneously breathing patient, or a Martin pressure, driving pressure in the Martin that you can say, so that the air will go into the chest. So that's what we call positive pressure ventilation. So I would like to talk about these 4 important pressures before we go for the mechanical ventilator. So there is airway AWO means airway opening pressure. So if I set the pressure on the margin as, for example, 16 centimeters of water, the airway opening pressure, or the pressure I'm applying at the opening of the mouth, will be 60. So A is the alveolar pressure, the pressure which is needed to determine the alveoli is called the airway, the PA or alveolar pressure. PL is the pleural pressure, which is the pressure in the pleural space. And PAW is the airway pressure, which is mainly concerned about the airway resistance, the airway, the upper airway resistance. And PBS means body surface pressure, pressure on the body surface. So these things, the body surface pressure and airway opening pressure for a spontaneously breathing patient is equal to the atmospheric pressure. How much is the atmospheric pressure? Anyone? You can answer in the chat box. How much is the atmospheric oxygen pressure? Anyone? So atmospheric oxygen pressure, so on the air is around 760 millimeters of mercury. It depends on the altitude actually. That's usually around 760 millimeters of mercury. So this airway pressure, opening pressure, depends if the patient is being applied with a positive pressure ventilator or not. So if you use a stop mask, it will differ. If you use a machine, it will differ. And if you put the patient in a hyperbaric chamber, for example, for treatment of carbon monoxide poisoning, for example, it will vary. So these pressures are very important. So the pressure that usually drives air into the lungs is the transpulmonary pressure, because it is the lung pressure. Alveolar pressure minus the pleural pressure will help to distinct the alveoli. So there is a trans airway pressure. This is a pressure that needs to overcome the resistance. So this is airway pressure minus the alveolar pressure. The pressure in the alveoli will give you the difference, which is the airway pressure. So whenever airway pressure is high, you think of that the problem in this patient is mainly related to airway resistance. So knowing about these pressures will help you to formulate the differentials to know what really the problem is in this patient. Okay. So we talk about the physiologists, basic physiologists. I think I should proceed on the basic mechanical ventilator terminology. So on the basic terminologies, we'll discuss on the mode, what's the trigger, and what does it mean by cycling. So mode is simply, it is a manner the ventilator braces are triggered. So how does the ventilator act in order to deliver brace to the patient? So the ventilator has its own parameters, be it a trigger, a cycle, a limit, and be aware that we will discuss these terms as well. But it's just a matter, or it's a manner how the ventilator delivers a brace to the patient. So እንዴት አድርጎ ብሬዝን ወይም ደግሞ እስትንፋስ እንዴት አድርጎ ነው ለፔሽንት የሚሰጠው በምንድን ነው የሚያውቀው የሚለውን ነገር about the mode of ventilation. Here means what initiates the brace, what the ventilator seems to initiate an assisted brace, and what will be the stimulus for the ventilator to give brace to the patient. So it could be the patient's inspiratory effort, or it could be a time-based signal. So we will discuss about triggering. So there are basically 2 types of trigger we can use in our ICU. So if you are working in the ICU, you know about what trigger is. Usually we use a flow trigger or a pressure trigger, and we will discuss how much should we set the trigger on initial mechanical ventilator settings. Okay. So cycle means what tells the motion to cycle its brace delivered from inspiration to expiration. So when will the inspiration should end, and when should the expiration start? So this thing is depends on the cycle. It could be volume. So if the motion, for example, cycles from inspiration to expiration after delivering a 400 ml of tidal, that's called a volume cycle. So if the motion cycles from inspiration to expiration with a pressure of 16 centimeters of water, that's called pressure cycling. So the usual cycling that we use is either flow cycling or time cycling. So mainly flow cycling or time cycling. So flow cycling and volume cycling are more or less similar concepts, because If you set the flow at the constant rate, then it will deliver a specified amount of volume. So the volume and flow cycling are usually related concepts, but you can also have pressure or time cycling. So we will see on a graph. Okay. So tidal volume, as you know, it is just the volume of air that's either inspired or expired with each normal press. So it's usually for an average adult. How much is the tidal volume for an average adult? I think you know these concepts. How much is an average tidal volume? Okay, I'm looking at number 6. What 6? Can you elaborate more? 6 means. Okay, the normal tidal volume is around 500 ml, right? Okay, 500 ml. So it's better to think of it as ml per kilo because there are also pediatric patients. We don't only have adult patients. Okay, so generally 8 to 10 ml per kilo. 8 to 10. It could also be as high as 12 ml per kilo, the normal tidal volume. So if you do it based on the physiological adult male, you can find around 500 to 600 ml of tidal volume. And minute ventilation is just the multiplication of tidal volume, the product of tidal volume times the respiratory rate. So per minute, how many volume of gas flow into the patient and out per minute? So if the respiratory rate of patient is 12 with a tidal volume of 500 ml, so 500 ml times 12, around 6,000 ml or 6 liters per minute will be the minute ventilation. Okay. Functional residual capacity is just the amount of air that will remain after a maximum. Not a maximal, actually, after the end of a normal expiration. If after maximal, it will be residual volume. So we were discussing about the common lung characteristics that we should know for a patient who is going to be ventilated on a machine. Compliance means something that means something that will accept easily. So can you answer in the chat box which one will be easier to inflate a balloon? Whether is that easier to inflate a balloon early or late? Which one is easier? Or you can also compare between a golf ball and a tennis ball. Which one will be more compliant or will be easy to compress? Will it be the tennis ball or the golf ball? Okay. So the golf ball will be easier to compress and the tennis ball will be difficult. So the ball that's easier to compress will have a very high compliance, which means it is very easy to accept a pressure change. Rather, the golf ball will be very difficult as it has a hard surface. It will try to retain its original space. That's called high elastance. So compliance elastance, they are inversely proportional, as you can see. So the higher is the compliance and the lower is the elastance. The higher is the elastance and lower is the compliance. And this can be shown on a clinical setting. For example, a patient with ARDS, which one do you think is a problem? Does it have a high compliance or a low compliance? The patient with ARDS with significant pulmonary edema. What do you think? So patients with ARDS, it's very difficult to ventilate. So they have a very low compliance and they have a very high elastance. The lung will try to retain its shape. So you need a very high ventilating pressure, very high PEEP to increase the oxygenation and to ventilate the lung. That's why the compliance of the lung with ARDS is very low. So as you can see, this lady is having difficulty of, I don't think she's having difficulty. At the surface doesn't look like she has difficulty ventilating. She's actually enjoying it, but what I'm trying to demonstrate here is you will have a very much significant difficulty while inflating the balloon at an early stage. So once the balloon starts to inflate, that means once the lung is starting to have uptick inside the alveoli, it will be easier and easier to inflate. That's why we apply a very high PEEP for a patient with ARDS so that it will be easier to ventilate with a low pressure. So as you go through inflating a balloon, you'll have easier pressure to ventilate the lung. So I think the concepts of ventilation, elastance, compliance elastance, I think it's clear. If there's any question, you can ask later. So the common cause of low compliance resistance, so you should know this is a Martian patient ventilator system. So there is a cause of high resistance here. So whenever there is high resistance, the problem is either in the tubing or in the upper airway tract of the patient in the ET tube, the ventilator circuit, in the upper airway tract. So any kinking in the ET tube, if there is any kinking or bending of the ET tube, if the patient is biting the tube, if there is a mucus plug obstructing the tube, or if there is airway secretion, bronchospasm, all these things leads to higher airway resistance. So the problem you see and the alarms you will hear and you will see on the graphic interface on the monitor will be a very high pressure, high airway pressure. But high airway pressure could also be caused by a lung problem. So there is a specific way of telling whether it is really an airway problem or a lung problem. So it depends on the compliance assessment you will see later. And the compliance is mainly from pneumothorax, alveolar consolidation from pneumonia, edema, or if the migrates to the right lung and it's ventilating only the right lung. So a significant amount of volume is entering only to the right lung, which was actually meant for both of the lungs. So this will create a very significant problem of compliance over the right lung. And increased abdominal pressure from massive assays, for example, and auto-PEEP can decrease the lung compliance. Is the concept of compliance in lessons clear? Can anyone respond? Can anyone hear me, or am I talking again? Okay, thank you. So compliance is as a mathematical formula, the correlation is the volume change per pressure change. So how much pressure should I apply to bring a change in the volume of the lung? So for example, if I use a 2 centimeter of water pressure to distend a lung by 500 ml of volume versus if I need a 10 centimeter of water pressure to have the same volume effect of 500 ml, which one is a highly compliant lung? The first one or the second one? If I use centimeter of water pressure to have a volume change of 500 ml versus if I use a 10 centimeter of water pressure to have the same 500 ml of volume, which one is a highly compliant lung? Which one has a better compliance, the first lung or the second lung? Okay, someone is saying the second one. Any different opinion? Okay, it's the first one, right? It's the first one. So you need a very low amount of pressure to bring a significant volume change. So that means the lung is complying. So it's easy to distend the lung with a very small amount of change in the pressure. If you need a significant pressure to bring some volume change, then the lung compliance is very low. So this is a mathematical formula. The higher is the pressure, the lower is the compliance, because it is indirectly proportional with the pressure change. Okay? So I think it's clear. So these are the normal compliance in a spontaneous breathing and in intubated patient. You can see the normal values and you can compare later on because we have an example to illustrate that. Okay. So S and C dyne, there are concepts of static and dynamic compliance. So static compliance is just the compliance of the lung when there is no airflow. So you should stop the airflow. There is a so-called inspiratory hold maneuver, or you can block the white tube of the connector and you can measure the compliance. So that's called static compliance, is the compliance of the lung when there is no airflow. But dynamic compliance is a compliance that the machine calculates while the air is still flowing into the patient. So that's why it's called dynamic. If you don't get the idea of these things, don't bother it. We'll address it. Resistance is just measurement, the measurement of frictional force that you should overcome while breathing. So this is the Poiseuille's law. So this formula is especially important for those of you who give caring for critically ill patients. So it's mainly related to the length in the arm. So this is just for a fixed tube. So if you think of the airway tube, so L is the length, and this sign, I don't know this sign. Can anybody tell me this sign? So anyways, this is called the coefficient of viscosity. So it's just the viscosity of the air. So if you see this formula, phi is constant. The length of the tube is constant because as long as the patient is already ventilated, the patient's airway tube is not going to grow overnight. So the length of the tube or the airway of the patient is always constant. And the viscosity of air is constant, more or less. So the one that varies for an intubated patient will be the radius. So this radius will change depending on the conditions. It could be bronchospasm, it could be airway secretion, it could be mucus plague. So anything that can reduce the radius of the airway will have a significant impact on the airway resistance because it's powered to the radius of 4. It's powered to the power of 4. So if the radius is, for example, half of the previous one, so the airway resistance will increase by 15 times. Cool. So the fold will be very much significant. That's why for patients with increased secretion, for patients with bronchospasm, nebulization and secretion of airway secretion will be frequent. Okay, so this has a significant impact for the patient. Okay, so the normal resistance, you can also calculate resistance based on the airway pressure divided by flow. So you have already mentioned about trans airway pressure. I have already talked about trans airway pressure. So the maximum pressure in the system, which means the PIP, there is a term PIP, peak inspiratory pressure. Peak inspiratory pressure minus the P alveolar, or the alveolar pressure, which means the P plateau pressure. So that the pressure that we give on our machine will be the P plateau, P plateau, PPLAT. So the PIP minus the PPLAT will give you the trans airway pressure, which means the pressure only needed to overcome the resistance of the upper airway, divided by the flow will give you the airway resistance. So most of the machines that we are using, as you have mentioned, you are using Mindray, and the Mindray is more of as a better user interface, and it can calculate the airway resistance. You don't have to calculate it using your own hands. Okay. So what are the definitions of pressure in post-pressure ventilation? What are the different types of pressure? So I will try to give you the basics. Okay, there is a baseline pressure, which means that. So can anyone tell me, do we have PEEP? Do we have positive index pressure? Do we have PEEP? In a spontaneously breathing patient, do we have PEEP? So we do have PEEP. At least 3 to 4 centimeters of water PEEP. We do have 3 to 4 centimeters of water PEEP. So whenever you put a patient on a machine, that PEEP should be safe. So there is no the so-called PEEP. Okay, don't put the patient with PEEP of 0 while the patient is on a machine. So the minimum PEEP allowed will be 3 to 4 centimeters of water, but usually for clinical purposes, usually it's around 5 centimeters of water is the lowest PEEP you can say. Okay? So this baseline PEEP, if it is 0, it's called PEEP 0 index expiratory pressure, and if it's at 5, you can say if it's at 5, it can be at 10, it could be at 20, you can say it's just positive pressure, positive index expiratory pressure. So it's just to simulate the normal physiology of residual volume. Whenever you expire at the end of maximal expiration, there is some residual volume of air in the lungs that will keep the alveoli slightly distended. So if you make it 0, you are causing alveolar collapse. So you need to set it at least 4 to 5 centimeters of water. So that's called the baseline pressure or PEEP. So never use this just to tell you the concept. Okay. So the peak is the peak pressure is the highest pressure which is recorded as in the inspiration. So this is what you call the patient is inspiring. While the patient is inspiring, the pressure in the patient ventilator system is building up, increasing, and reaches maximum. That is called the peak inspiratory pressure. So this is the peak pressure. And if you stop the movement of air with the so-called inspiratory hold maneuver, most of the machines have this button, inspiratory hold button. So if you put the inspiratory hold button, the pressure will become static because there is no airflow. So this is just a pressure that's lying inside the alveoli. This up to this point. So it's called the plateau pressure. So the plateau pressure is right from this. So around 35 centimeters of water. The peak pressure is around 40. The pressure that you need to overcome the airway resistance that we have said before, PTA or trans airway pressure, will be the difference between the peak inspiratory pressure and the plateau pressure. Is this concept clear? Clear. So you need to have an inspiratory hold maneuver. Okay. So I think someone is raising his hand. I think he can proceed. Okay.
So if participants have questions, they can write it in the chat box. So you can continue, Doctor.
Okay. So when you come to the modes of ventilation, the commonest modes of ventilation are the volume control ventilation, pressure control, and pressure supported ventilation. These are the commonest ventilation modes that we use in our day-to-day activities. Okay. In the volume controlled ventilation, it's mainly you are controlling the volume. So the volume of the patient is not variable. You can take the volume. You have a set amount of volume. So that's the independent variable. It's not dependent on the patient characteristics. So if you put around 400 ml, so the machine is going to give 400 ml of air, whether the patient has increased airway pressure or not, it doesn't matter. So it really gives 400 ml of tidal. So the independent variable will be the tidal volume. So the dependent variables, the variables that are going to change for the patient will be the pressure and the flow. In a pressure control ventilation, the reverse. The pressure will be controlled if you set the pressure at 20 centimeters of water. The machine is not going to exceed this set pressure. Rather, the tidal will vary. For example, a patient with significant low compliant lung with severe air base. If you set a pressure of 20, it can give a tidal of around 200 ml, while the same pressure of 10 centimeters of water can give a tidal of 500 ml for a normal lung. So the dependent variables are the volume. The volume is varying depending on the patient's lung condition. For a normal lung, it would give a better tidal volume. For a diseased lung, it would give a very low tidal volume, but the pressure doesn't change. Okay. Pressure supported ventilation, the independent variable here is flow. So pressure is controlled. So the dependent variable, the volume, the pressure varies, but the flow does not vary. Okay, it depends on the mode. Pressure support ventilation usually can be blended on the synchronized intermittent mandatory ventilation usually can be used alone. You will see the difference, okay, based on the graph. Okay? So these are so if we talk about the modes, pressure, volume control, I think it's better to understand it with the graphs, okay? Otherwise, it will be very difficult. So if you see volume control, if you are doing a specified amount, these are called scalars. Any variable that's set against time, any variable which is set against or which is plotted on a graph against time will be said to be scalar. And there is also loop. So we are not going to use scalar loop waveforms in this seminar beyond the scope of this presentation, but just to give you the overall idea, this is called the scalar. You can see this is pressure time curve. The volume control, you can see the volume. The volume is linearly increasing and the pressure is also increasing, but it does not pass the set volume. If the set volume is 500 ml here, so it's consistently 500 ml. Okay, it's constantly 500 ml. But the pressure is, as you give volume, the pressure will start to increase, and cycles to expiration, inspire, increase, and cycles to expiration. But for a pressure control, since pressure is the control, so there will be, if you set the pressure at 20 centimeters of water, it will be constant. Okay, it will be constant at 20 centimeters of water. The difference always is on a flow time curve. So this is called waveform for a flow time curve. This is called a rectangular waveform. So when you see a rectangular waveform on a flow time curve, it's always volume controlled. It can't be a pressure controlled. It's always a volume controlled. So if you see a flow time curve, the same link, it can either be pressure or volume, because for a volume control, you can use a flow time curve, both the constant one or the descending one. But if you see a constant flow time curve, it's always volume control. A pressure control ventilation cannot have a static or a constant flow time curve. Okay, so that's how you can differentiate. Even though the volume control, pressure control are not given, you can see the graph and you can see what mode of ventilation is really ventilating the patient. Okay, so we will do exercise and you will answer me on the chat box. What type of ventilation are we dealing with? So what do you think is this ventilation? Anyone? Anyone can answer. Okay, volume control, very good. Volume controlled. I think it's clear. It's volume control. Because you can see the volume is constant, and if you see the flow, there is a constant rectangular flow time waveform, and the pressure actually is increasing, because in a volume controlled ventilation, the pressure will increase and it will come down. So what are these? What do these sharp spikes indicate on a pressure time curve? What does it indicate? Can anyone answer? The sharp spikes. This case, for example, has a sharp spike, and this one here doesn't have any sharp spikes. What does it mean? Good. Patient trigger. So the patient is triggering. So if you, for example, if this baseline pressure is, for example, 5 centimeters of water PEEP, think of this baseline pressure as 5 centimeters of water. So if it is a baseline pressure And if the patient is breathing, so the patient's breath is always a negative pressure, so it will tend to bring the pressure down, okay, to the negative deflection. So for example, if you set the pressure at -2 and you set the PEEP 5, at what pressure will the patient trigger the muscle? If you set a pressure sensitivity at -2 centimeters of water, and if the PEEP of the patient is 5, at what pressure will the machine deliver brace? Can you answer this one? So you have already a set pressure of -2 centimeters of water, pressure 3. Very good, plus 3. So 3 centimeters of water, when the pressure reaches at 3 centimeters of water, the machine will know that the patient is trying to inspire because the already set pressure was 5. In the meantime, there is a drop in the pressure by 2 centimeters of water because your pressure trigger is -2. So when the patient's machine ventilator system pressure becomes plus 3 centimeters of water, the machine will try to give the patient the desired brace. So the types of braces on a patient will be patient triggered brace. This is mandatory brace which is given by the machine depending on the time. For example, if you take the rate of 12 for a patient, every 5 seconds the machine is going to deliver the brace. So this is a controlled brace. This one is patient triggered brace. There is also a patient triggered but machine assisted brace. So there are 3 types of brace: assisted braces, controlled brace, and triggered braces. And we'll continue the exercise. What do you think is the ventilation mode here? Can you answer the ventilation mode? Pressure controlled mode. It's clear. Pressure controlled. So the pressure is constant. It's not variable. Rather, the volume of the patient might vary. Okay, it may not be constant as you see in this graph. It might be variable. The volume of the tidal volume might be variable. But the flow for a pressure controlled ventilation, the flow waveform will be a descending ramp. So it will be a descending triangular form. It doesn't have to be a constant form. It will never be a constant form. It will rather be a descending form. So if you see a descending flow time waveform with a constant pressure time curve, that's definitely pressure controlled ventilation. So what do you see? What's the mode of ventilation here? And what's different from the previous one? Okay, I'm hearing pressure support ventilation. Pressure support ventilation will have a constant pressure. Here you are not having a constant pressure. The pressure is continually increasing until it reaches its peak. So it will never be pressure support ventilation. So it is a volume controlled ventilation, but the difference is this is inspiratory hold. So when the inspiration is hold for a brief second, you can see the plateau pressure. So the pressure in the absence of airflow, and this is the maximum pressure in the system, peak inspiratory pressure. Difference here is the airway pressure. So you can see the volume time curve is constant. So whenever the flow time curve or the flow time curve is constant, you will consider volume control ventilation. You should never consider. If you see the volume time curve as well, there will be a flat stop, a plateau, because of the stop in the inspiratory phase. There is inspiratory hold, this inspiratory hold will hold the flow time curve as well, and will also hold the volume time curve. What about this one? I think this one is a bit different. Can anyone try this? Can anyone try this one? Of course, it's a volume control, but what's the difference? It's volume controlled. Thank you, it's volume controlled, but what's the difference? So here it's a volume controlled. So this one is volume controlled. But what type? Is that AT, SIMV? So here the patient has triggered and volume is delivered, and there is a patient trigger but is not supported, and yet there is also a patient trigger is not supported. What do you think is this ventilation? Okay, good, SIMV. Okay, it's called SIMV volume control. It's a volume controlled SIMV mode. Okay, this one is volume controlled SIMV mode. Because whenever the patient breathes, it will allow the patient to breathe, but when the time comes to deliver a brace, and when the machine tries to synchronize, so there is a synchronization window, there is so-called 0.5 to 1 second synchronization window. For example, if you set the rate at 12, the brace will be delivered every 5 seconds. Yes, every 5 seconds. So at 0 second, deliver brace, and at 5 seconds, there is a mandatory brace that's going to be delivered. So if the patient triggers at that point, it will blend in with the motion. That's why the term synchronous is used. So it will synchronize. If the patient breathes in that 0.5 to 1 second window, synchronization window, it will count it as a major mandatory brace and it will assist the patient brace. Otherwise, if it comes in between, well beyond or well away from the synchronization window, it will allow the patient to breathe by his own. So that's why it will allow the patient to breathe by their own, and it will enhance respiratory. Okay, it will prevent ventilator dependence. So even though it's not that much advisable mode for weaning, it can be used. Okay, so I think it's clear. Anyone not clear about this mode? So you can write your questions and you can ask later. So what will be the mode here? Still the same. SIMV volume control. SIMV volume control there. Here as compared to this one, here the tidals are very low. So we are putting a little bit of pressure here. So there is a safe pressure support. These are blended modes of SIMV, volume controlled SIMV with pressure support ventilation. So most of the machines currently use SIMV pressure support blended modes. Okay. So the spontaneous breath that the patient is trying to breathe will be supported with a simple pressure to overcome the airway resistance. So that's where tidal volume will be augmented. So the tidal volume will be augmented. So the variables that happen while ventilating a patient, there are phase variables, control variables. So phase variables are what variables will change the phase from baseline to inspiration to the end of inspiration, expiration baseline. So these are called phase variables. Control variables are what controls the machines to deliver breath. It could be volume, it could be pressure, or it could be flow. I think these are very clear by now. So this is the starting inspiration. So this is a baseline pressure. One of the baseline variable for a baseline pressure will be the positive end expiratory pressure. Positive end expiratory pressure, the PEEP. So this is the baseline pressure. You can set it at 5 centimeters of water. So when the patient starts to breathe, the pressure in the patient ventilator system will start to raise to the set pressure. If it's pressure controlled, it will continue to rise to the set pressure. Same inspiration will occur, volume of gas will enter into the patient. Then at end inspiration, for example, it will change into expiration. This is what the cycling is. So this is the phase where inspiration changes into expiration. That's called cycling. So there are also cycle variables. So their time cannot be used for a cycle. Time can be used for a cycle. Volume can be used for a cycle, and pressure can also be used for cycling. If the patient is at a set pressure of 30 centimeters of water, it should cycle to end inspiration. Or if you set a volume at 100 ml, then the patient, when it reaches 100 ml of volume, it will cycle to end inspiration and cycle to expiration. So these are cycling variables. Limit and cycle are different concepts. So limit means that by definition, time cannot be a limit variable. If we set time as a limit variable, you are harming the patient. For example, if you don't care about the patient, okay. So if you set, for example, time as a limit variable, by the time if you tell the machine to give brace for the next, for example, let's say 4 seconds, it doesn't care about the patient, whether the patient is already standing, whether the patient is having significant pressure in his airways. It will deliver the volume of gas for that specified time. So time should not be a limit variable. So either use a volume, flow, or pressure for a limit variable. Okay? So pressure, volume, flow we have already talked. Cycle variable, we have already mentioned these things. So the baseline variable we have already talked about these things. Okay. So volume cycle can be volume control, AC control, SIMV, or intermittent mandatory ventilation or SIMV. So the commonly used are SIMVs and ACs in our setting. So the controlled mechanical ventilation is usually used for those patients who are deeply sedated, especially for a general anesthetic purpose, especially for surgical operations, okay? Especially used in the OR units, controlled mandatory ventilation. For ICU settings, the usually used most are AC, acid control, volume control, or synchronized intermittent mandatory ventilation, volume control. So AC, VCV, or SIMV, VCV. Okay, is that clear? So these are the common used. From the pressure cycle modes, the commonest used are PSV or pressure support ventilation or pressure control ventilation. So this can also be PTV, AC, PTV, SIMV, okay, and CPAP and BiPAP mode. Okay. So control mandatory ventilation we have already talked. So it's just its aim is to fully guarantee the minute ventilation by setting the respirator in the tidal volume, and it assumes that the patient has no respiratory drive because he's deeply anesthetized with inhalation anesthetic, especially in an OR setting. Okay. So these things can summarize your common ventilatory modes, the variables, the independent, dependent variables we have already talked. So the advantage of controlled mandatory ventilation is just raises the muscles of respiration and it helps to stabilize the respiratory muscles. So you don't need for the patient to inspire while you are operating on the abdomen, for example. So you can guarantee the specific respiratory rate and tidal volume with a controlled mandatory ventilation, and you can perform your procedures. The disadvantage is it requires heavy sedation in neuromuscular blockade, and it can have a potential hemodynamic adverse events, and you should be careful on that. So the assist controlled ventilation AC mode, every breath is inspiratory cycle is initiated or triggered by the patient. It can be by the patient inspiratory effort. If there is no patient respiratory effort within a specific period of time, there will be a mandatory breath that's going to be delivered. For example, you can see here, whenever a patient breathes, it can be a full breath, that's called assist. A patient also here tries to breathe, it gives a full tidal volume, that's called assist. But when a patient is unable to trigger breath, and if it is time to give breath based on the time or the rate you set, if the patient has to receive the tidal volume, it will give it a full tidal as well. So whatever is the breath initiation, whether it's patient breath or a mandatory breath delivered by the machine, it will always give a fixed tidal volume. Okay, that's why it's called either assist or controlled. Assist control mode. So it will either assist or control. So whatever is the case, whether the patient breathes or not, it will give mandatory tidal. Okay, so if you see the respiratory rate 15 liters in breath per minute in the tidal 500 ml, it will give you around 7.5 liters. So it should always be. Okay, so this is AC mode or assist controlled mode. Okay. So the advantage, it can give you a backup minute ventilation, and it may allow for synchronization, but the problem is since the patient assisted breath is also supported by the machine with a full tidal, it faces a risk of respiratory alkalosis and tachypnea. For a patient who is tachypnea from some other cause, be it anxiety, pain, airway irritation, whenever they try to inhale, the simple patient trigger will be changed into a full tidal support. So that will increase the risk of respiratory alkalosis, and it can also cause seizure from hypokalemia. So it can also lead to dynamic hyperinflation. Think of any air entering into your lung and you don't have adequate time to exhale, and another breath will enter into your lung and you don't have adequate time to exhale. It will continually increase your lung volume and will result in dynamic hyperinflation. That's also called auto-PEEP. That's the concept of auto-PEEP or dynamic hyperinflation. Also, dynamic hyperinflation is also concerning disadvantage of assist control ventilation. So whenever you try to use assist control ventilation, usually your patient preference is a patient who is heavy sedation or neuromuscular blocking agent. Intermittent mandatory ventilation, intermittent mandatory ventilation, as you know, that the main thing that we are going to focus here is synchronized. It's just they are similar intermittent or synchronized, but the breaths that are initiated by the patient here in a synchronized one, it will be synchronized with a 0.5 to 1 second synchronization window. So the major difference from assist control is it allows the patient to breathe spontaneously without the ventilator assist. Okay, you can see here. So the graph will make it easier for you. So there is a spontaneous breath here. The spontaneous breath, but the patient triggers in the synchronization window, so that the machine will deliver the full tidal. But here the patient is not triggering in the synchronization window, so that it will allow the patient to breathe. And here the patient is unable to trigger, so that it will continue the mandatory breath. It will go to the mandatory breath. But if the patient, for example, triggers here, it will coincide or synchronize it with the normal mandatory breath. Is that clear? Is that clear, or is there any ambiguity? Okay, thank you. So I think we have already talked about the advantage of SIMV. Its time backup is useful for weaning, and it's questionable. The use for weaning is actually currently questionable, but you can use it. Okay, and there are also limitations, especially airway pressure may exceed. Ventilator-assisted breaths may be aborted sometimes. So those patients with tachypnea, and usually the patients who are tachypneic and who are already not really ready for weaning purpose might fatigue from SIMV. Okay. So the last one will be CPAP. CPAP is the commonest used ventilation, especially for patients who are in mild air days, for patients with acute cardiac pulmonary edema, for patients with acute asthmatic exacerbation. You can use CPAP, and you can also use CPAP as the post-extubation management. Okay, so it's not a true support; it's just a pressure support. Okay? All ventilation will occur through the patient spontaneous effort. So all ventilation is dependent on patient spontaneous effort. Especially those working on the pediatrics as well, you can have a locally made CPAP. Those also have similar effects. Okay, so it's usually used to assess for extraction potential for patients who don't have spontaneous breathing. Especially for those of you who are using ventilator, you can use a CPAP to assess for whether the patient is extubable or not. So you can assess daily whether he's tolerating CPAP or not. And you can also use a TP. Okay. So pressure support ventilation is what we call the PSV. It's also a purely spontaneous mode, but its PSV is usually used for invasive mode of ventilation usually. So the patient is already invasively ventilated with ET tube, and you can take the pressure support ventilation, and it's mainly used to overcome the airway resistance from the tube, the ET tube, the ventilator circuits. It doesn't really give a tidal volume. Okay, so it's commonly recently being used as a weaning mode currently. Next to the daily spontaneous breath trials, you can use pressure support mode of ventilation. Okay. So the pressure control ventilation is already in the graph. So ventilator controls the pressure, but the tidal will vary. Okay. Tidal volume will vary based on the patient and the lung parameters. Okay. So the advantage of PCV especially is there significant air leaks. For example, for patients who have thoracic surgery, those patients with bronchopleural fistula who have a few leaks, for example, you need to guarantee the pressure to derive the volume of gas. Okay, you don't guarantee a tidal volume because the tidal volume will be lost. So the tidal volume should be left to be decided by the patient. So you need to control the pressure for patients with pressure leak, and for patients with a pre-existing barotrauma, for example, subcutaneous emphysema, pneumothorax from a ventilation problem, you can use a pressure control ventilation to control the pressure well. Okay. So disadvantage, it may be difficult to guarantee your minute ventilation because you can't adequately set the tidal volume because it depends on the patient. So guaranteeing a minute ventilation will be very difficult in such kind of patients. Okay. So depending on which mode of mechanical ventilation do we need to use, it all depends on the clinical experience in our protocol. So don't sweat about it in general. Okay, you can use any mode. What matters is which specific disease parameter might need a specific mode of ventilation. For example, if you can use volume control for patients with asthma or ARDS. So it doesn't mean it has to be always. So the only thing you have to use is, especially for ARDS, you can use lung protective ventilation. So make sure that the tidal volume is kept at the lung protective ventilation strategy between 6 to 8 ml per kilo. So you can calculate the same amount of pressure that can give that same amount of tidal volume. So it doesn't have to be always to be a volume controlled ventilation. Okay. So there is an international survey. Then on the use of mechanical ventilation, you can see which preferred modes are the volume control, pressure controlled modes are mainly used for ARDS patients, even for patients where volume has to be controlled, they are even using a pressure control. So it doesn't mean it has to be always volume control, but make sure that you are using lung protective ventilation strategy whenever you are facing ARDS. For COPD, they are using volume control. So this is an international survey. Okay, it has included around 150, if I'm not mistaken, countries, and clinical experience also matters. Okay, on the use and the choice of mode of ventilation. And weaning also has been studied in 1995. And as you can see at the conclusion, a once daily trial of spontaneous breath trial is usually used. So those of you who have a mean ray machine, you have a daily spontaneous breath trial for a 30-minute duration. You can increase the duration of breath trial every day, like up to a maximum of 2 hours, maybe 120 minutes. But the main aim is to use SPT or daily spontaneous breath trial, with a built-in SBT mode for a main dry machine. For a Philips machine, you can use a CPAP or pressure support ventilation mode for a patient to access weaning. Okay. Otherwise, the use of a SIV mode or other mode for weaning is falling out of favor recently. So these are the initial ventilator settings you can use. One thing we can summarize from this table, I don't want you to stuck on the table, you can very detailed the table, but for a pressure controlled ventilation, the variables that you are going to insert are the pressure, the time, the pressure, the PEEP, the FiO2, and the inspiratory flow in the case of volume controlled. So, and the frequency as well, the respiratory frequency. So the things that you are going to insert for both volume and pressure control modes are the respiratory frequency, the PEEP, and the FiO2. These are common for both of them. So the things that matter are the tidal volume and the pressure. In case of the pressure one, the tidal volume has to be set and the flow has to be chosen as well. In case of volume control. In case of pressure control, the pressure has to be set. Okay. And trigger. Trigger is also very important. Okay. Trigger should be set for both of them. Either pressure trigger or flow trigger. Okay. So ventilator parameters, there are ventilator parameters that you can use to increase oxygenation, ventilation. I think I can use 5 minutes to summarize. I use 5 minutes to summarize, Dr. Hema. I think, is everyone listening? Anyone? Okay. I think it's audible. So there are parameters to improve oxygenation. So
yes, I'm also having a bit of a connection problem. So yeah, it's better to wrap up the session so we can summarize. Yes.
Try to wrap up. I'm left with 4 slides, I think. Okay. So in order to improve oxygenation, if your aim is to increase oxygenation, your parameters that you are going to manipulate are the FiO2, the PEEP, and the IE ratio. Whenever you increase the IE ratio, you are delegating more time to inspiration so that oxygenation will increase. Whenever you increase the PEEP, you are recruiting more alveoli, you are descending more alveoli so that you can increase oxygenation. Whenever you are increasing FiO2, you are delivering a high amount of inspired oxygen, okay? But beware of the risk of oxygen toxicity. Whenever there is no need for high FiO2, try to reduce FiO2 to below 60% in the first 24 hours if possible, okay? So parameters to improve ventilation are usually frequency or respiratory rate and tidal volume. Whenever you increase the tidal volume or the respiratory rate, since the minute ventilation is the product of both, either increasing the respiratory rate and tidal volume or increasing both can increase the minute ventilation and can improve your ventilation abnormality. Okay. So this is a sample case scenario. Can you do it? Can you do the sample case scenario? So case 1 is a 25-year-old male with severe pneumonia intubated for severe AR days. So which mode do you want to use? Which mode do you want to use? Anyone? So it's preferable to use volume controlled ventilation with AC mode, AC volume control mode, because is intubated, is a likely need of increased need for sedation because the patient has severe AR days. It likely has to be ventilated with a deep sedation, okay? So you are going to choose AC mode preferably. So volume control mode is preferred because this patient need a lung protective ventilation. Tidal should be set at 6 to 8 ml per kilo. So the kilogram is not a normal actual body weight. It is an ideal body weight. It has to be calculated based on the T-Boy's formula, okay? Ideal body weight should be calculated. You can have a simple application on your phone, or you can, the new machines, especially the Mindray machine, can calculate it for you, the ideal body weight based on the height of the patient. You can input the height of the patient as a variable by using a tape meter, and it can calculate the ideal body weight. So based on the ideal body weight, the tidal volume should be set at 6 to 8 ml per kilo of body weight, okay? 6 to 8 ml per kilo. And the rate for patients, the air rate should be higher because you are limiting the volume, you are using lung protective ventilation. So in order to maintain the minute ventilation, one parameter you have is the respiratory rate. So the respiratory rate should be set somewhat higher than the other patient counterparts, okay? So respiratory rate should be used at a rate of 18 to 30, as high as 35, okay? 20 or 18 to 30 or 35 breaths per minute can be set. And usually the flow is set at 60 liters per minute. Flow is usually set at 60 liters per minute. And FiO2 usually you start with 100%. For most of patients, FiO2 should start 100%, but if there is no need for that high FiO2, you should escalate, okay, subsequently. For the second one, what's the difference? I think that's important to see the difference otherwise. Okay, volume control should be avoided. I'm seeing an answer, volume control should be avoided for the second one. I don't see any reason to avoid the volume control. You can use volume control, pressure control. So the main issue is preferable to use volume control. Rather, it's preferable to use volume control. What's the difference? Yes, so it can be based on experience, can use volume control, pressure control. I'm looking at an answer. So the main thing here is a patient with COPD have a main airway obstruction problem. So the main parameter that we'll think here is the respiratory rate. So in order to avoid dynamic hyperinflation and auto-PEEP, so you need to allow more time for exhalation so that the air will come out of the lung, because the lung has a very significant airflow limitation. So you will have the IE ratio should be low for a normal patient. Inspiratory to expiratory ratio, this parameter, IE ratio should be 1 to 2 or 1 to 3. For a patient with COPD, you can set it at 1 to 4 or 1 to 5, so that you are allocating more time for expiration, so that air will not be trapped within the lungs of the patient. So that's a very dangerous complication for a patient with airflow limitation, like COPD or asthma. And flow should be higher. If we use a 60 liters per minute flow rate for air days, we need to use 80 to 100 liters per minute of flow for COPD patient. So that's whenever the flow is very high, you can give that specified needed volume within a very short period of time, so that you will have more time for exhalation. Okay. So NIPPV is non-invasive post-pressure ventilation. You can use either face mask, nasal mask. So this one is not a major aim of mechanical ventilation in this particular topic. So it's just non-invasively without the use of endotracheal tube. You can also apply post-pressure ventilation. Most of you has already been exposed for this non-invasive post-pressure ventilation, especially during the era of the COVID. So most of you know about CPAP, BiPAP. I think I don't have to sweat about this anymore. So the BiPAP is the only difference is bi-level positive airway pressure have positive pressures. IPAP and EPAP, or inspiratory positive airway pressure and expiratory positive airway pressure. So at least the inspiratory positive airway pressure should be 2 to 3 centimeters of higher, 3 centimeters of water higher than the EPAP, and usually used for acute cardiogenic pulmonary edema. And you can give a kind of NIV before intubation, before rushing to intubation. Okay. You can also use it for acute COPD exacerbation. CPAP can also be used, but usually the pressure is constant both during inspiration and expiration. Around 5 to 15 centimeters of water is commonly used. And there are, of course, contraindications to use NIPPV. So you can see the contraindications, especially any recent facial trauma, any recent gyanostomosis, severe GI bleeding, hemodynamic anesthesia patients are not candidates for NIPPV. So if there is an indication for invasive ventilation, don't use NIVs. Okay. And mechanical physiological consequences after you put on motion, there are pulmonary effects, barotrauma, auto-PEEP, ventilator effects, lung injuries can happen, cardiovascular effects, special hypotension is the dangerous risk. The GI effects, stress after GI bleeding, that's why we need to put them on GI alter prophylaxis. That's one of the universal care in critical ill patients. And CNS effects, especially sleep deprivation, delirium, agitations can also happen. So as the last slide for you summary, this is the thing that you should know while you put a patient on a machine. Okay. So whenever a patient that you put on a machine becomes acutely unstable, you need to think of these two things. Okay. Whether the patient is acutely stable or not. So if the patient is not acutely, is acutely unstable, so there is a mnemonic you can use. Okay. So D is for dislodgement, O is for dislodgement of the tube might dislodge. Obstruction means the tube might have obstructed. P is for pneumothorax. So these are the killers. Okay. And finally, after you search for DOP, you can consider E. E is for equipment failure or failure of the machine. So as you can see, the main aim of assessing an acutely unstable patient is navigating between the system of the patient and the machine. So the patient is a priority always. So you should segregate first the patient. So that's why you should remove the patient from the ventilator, and you will start manually bagging with 100% oxygen. And you will examine the patient. If you are facing a very significant resistance while bagging the patient, it could be obstruction, so you need to suck out. So if you can pass the catheter, if you can suck, then the obstruction is unlikely cause. So you need to think of pneumothorax. You can do needle decompression. You can also use ultrasound assessment to look for any pneumothorax. But if you suspect pneumothorax, it will be completely the right away process before going for ultrasound or imaging. Okay, so you can do needle decompression. So if the patient has improvement after the needle decompression or after the secretion is sucked out and everything, so you can connect the patient again and you can look for grafts, the patient ventricular grafts, to look for the specific cause of the problem. Or if there is no improvement, still presumptively treat for tension pneumothorax with needle decompression and test tube. Okay, and you should also consider other vascular causes like pulmonary embolus. So if the patient is not acutely unstable, what means if the patient is giving you time to analyze, you can confirm whether the division planes, and you are here allowed to evaluate for airway pressure, peak inspiratory pressure in plateau. So if the peak inspiratory pressure is affected, the peak plateau is normal, then the problem is in the airways, not in the lung. Okay, this one pressure tells you a problem in the lung, and this one tells you a problem in the airways. So if IP is high but the peak plateau is normal, then the problem is in the airway. It could be thinking, the patient might be biting the tube from inadequate sedation. It could be secretion, so it has to be sucked out. Everything has to be addressed early. But if both PIP and P plateau are raised, then the problem is in the lung. So it could be worsening of lung function, pneumothorax, abdominal distension, or in the likes. Okay. So if it's only the PIP that's elevated, then the problem is in the airways. I think, having said this, I think these are my references. You can look at them. I think we can have the PDF file as well. Okay. So thank you. So if there is any questions, comments, you can forward. The floor is open for the participants.
Okay, thank you very much, Doctor. So on today's presentation, because we took enough amount of time, it's better to skip the question and answer section and the session. Maybe we can address one, maximum two questions, if there's any from the participant side. Okay, Doctor?
Okay. So okay. I think there is one question that says how to manage dynamic hyperinflation. Okay. So as I have said, dynamic hyperinflation, the problem is either you are setting the respiratory rate too high so that the patient is not having adequate time for breathing. So you need to decrease the respiratory rate. So if you set the respiratory rate at 20 and if the patient is having dynamic hyperinflation, you need to disconnect the patient from the machine. You can mechanically compress the chest to allow to exhale the air, and you can set the respiratory rate lower at 14 respiratory rate, for example. And there is also other ways of managing auto PEEP or dynamic hyperinflation. You can set the PEEP to 80% of the previous one. Okay, you can increase the PEEP by 80% so that it will be easy for the patient to trigger the breath. Okay, this one is more or less a difficult concept. You should know about the ventilator graph in order to understand whether applying a PEEP or increasing the PEEP will solve an auto PEEP problem or a dynamic hyperinflation or not. But the basic thing that you can do is you can manually compress the chest for low, exhaling the air, and you can reduce the respiratory rate. So that's how you are going to decrease the or to publish the dynamic hyperinflation. So it's usually a problem in your setting. Okay.
Okay. One last question. Can you see, is it important to set PEEP in addition to auto PEEP?
So yes, it's important. That was what I was talking about. So auto PEEP means the patient is increasing a PEEP in addition to the set PEEP. If you apply a PEEP of 5, for example, and if you do expiratory hold maneuver, just like inspiratory one, there is also a so-called expiratory hold maneuver. So you can apply expiratory hold and you can see the PEEP. So if you say PEEP was 5, and if at the end of expiratory hold, if the total PEEP you are seeing is, for example, 10, that means the patient is having an auto PEEP of 5. So the 5 does not come from anywhere. It comes from the patient's dynamic hyperinflation. So if you, for example, decrease the rate, the auto PEEP of 5 may decrease to 7, for example. And if you set the auto PEEP, if you set the PEEP to 8, for example, it will be easier for the patient to trigger brace, for example. If the total PEEP is 10, the patient has to trigger brace to the level of 5 if the patient develops auto PEEP. But if you set the PEEP, for example, at 8, it only has to come down at units below 10 to trigger brace. So it will be easier for a patient to trigger brace if you set it a higher PEEP. Whenever a patient develops auto PEEP, you need to increase the PEEP to publish it. Okay, not decrease. Okay, mostly the practitioner tend to decrease the PIP. You don't decrease the PIP to troubleshoot an auto PIP. You rather increase the PIP. Okay. I think you have got the idea.
Yeah, thank you very much, Doctor. So, on behalf of Blue Hills Ethiopia and all our participants, thank you very much. Despite the network problems, I can say this was one of the best presentations and quite interactive one with our participants as well. I would also love to thank the participants for your patience and your active participation in the webinar. So, Dr. Surafel, we hope we will have future sessions with you. And if you have any last remarks, let me give you the stage one last time.
So, thank you, Dr. Thank you all the participants for your attention. So I think it might help you a little bit on your day-to-day critical care and the emergency medicine exposures as well. So it's just a beginning. So there is a very deep and vast topic. So you can go in and experience, especially with the clinical inputs and with the simulations. And there are multiple videos. And beware of the infection preventions as well. We are not addressing that topic here. So infection prevention and know your machines. So as a last remark, what I want to say is know your machines and know your manual for your machines. Okay, unless you know how to operate your specific machines at your specific institution, it might be difficult because it may not be similar. It's just the basic concept that's going to be similar. It will vary. The buttons, everything will vary. So it's good to recap your manuals. So thank you, Dr. Hino. Thank you all the participants. I think this topic will help you a lot in the future, and we'll meet in the future.
Thank you very much. We would love that as well.
Okay. Thank you.
Good night, Doctor.
Good night.